All right, thank you very much for that warm welcome. I appreciate it. This is actually my very first CFRI, so it will hopefully become my favorite as well. And I'm very honored to follow Luke. We actually did the plenary last year together, so it's just warm, fuzzy feelings right up here. One of my favorites. So little disclosures: I have grant funding from the CF Foundation related to this topic, and I've done some consulting as well. So what we're going to cover today is just a little bit about efficacy of Trikafta, Alexacaftor, Tezacaftor, Ivacaftor, just kind of more how we're going to relate that to sexual and reproductive outcomes. Describe some fertility issues in CF and how that may or may not be affected by the modulators we have. And then we're going to describe what we know about the impact of the modulators on contraception, pregnancy, and lactation as well. So, as we know, highly effective modulator therapy, we consider that ivacaftor and certain genetic mutations, as well as trikafta. We know that it improves outcomes. And so, in the clinical trial, FEV1 increased by about an average of 13%. Importantly, pulmonary exacerbations, meaning needing IV antibiotics, decreased by about 65%. Weight gain was appropriate, and we know that highly effective modulator therapy is available for the majority of people in the US, about 93%. And so the projected growth of the adult CF population is exponentially growing over the next several decades. Because of that, many people with CF are really contemplating, hey, I'm healthy enough. I want to start a family. Lots of different ways to do that. So let's first talk about fertility in CF, and I'll give you a little warning. We're going to have some figures of reproductive anatomy on the next slide. So, waking everyone up after that lunch. So this is anatomy in people without CF. So we'll focus on the left at first, the male reproductive anatomy. And what I want to point your attention to is the presence of those two tubes, the vas deferens. So those tubes connect the testicle to the prostate and to the penis. So basically serves as a tube transporting sperm to where it may need to go. On the right is a normal female reproductive anatomy. And what I want you to focus on there is all the tubes and the uterus is open, clear, and free. And here's what happens in people with CF. So on the male on the left, you can see that the vas deferens are absent. And so there's no tubing to connect the testicles to the prostate and then the end of the penis. So sperm cannot get to where it needs to go to potentially fertilize an egg. And then in the female reproductive organs, what you see there is thickened mucus. The cervix is filled with thickened cervical mucus, almost like the lungs. And then what happens here is that eggs cannot implant to where they need to go if it's been fertilized by sperm. So fertility in females with CF, there's similar reproductive anatomy to females without CF, but the CF protein causes dysfunction. So just like in the lungs, when people with CF have thickened mucus, and I'm sorry, I had somehow messed up these slides earlier to have a timing on them, and we thought that was fixed, but it's not. So that's why I'm switching a little bit back and forth. It should stop shortly. The CF protein leads to thick mucus. So sperm, if within the reproductive tract, can't get to the egg to fertilize it. With nutritional status, and we know that females with CF have delayed puberty, that also leads to issues with fertility. And a lot of previous studies have shown there's a subfertility rate subfertility means that women with CF have a harder time getting pregnant, and about almost half of pregnancies in women with CF are actually unplanned. And so the question becomes, can we see an increased fertility rate caused by CFTR modulators? And they likely do, and we've seen this. There's better health, there's less cervical mucus thickness, and the pH has normalized within the reproductive tract. And we kind of got a hint of this because ivacaftor was the very first um, clinical trial of CFTR modulators. And we saw in that trial, 2% of females actually got pregnant during those trials. And then there's cases, and we've all probably seen this clinically, of women who were previously infertile, they became pregnant after starting highly effective modulator therapy. This is a study that I really love. This is showing images of the uterine wall in a person with CF, a female with CF, using ultrasound, using hysteroscopy. So on the left, prior to starting ivacaftor, you can see the uterus is filled with that thick mucus. On the right, 3 months after starting ivacaftor, you can see that the mucus is completely gone and that uterine wall looks normal. So let's talk about men with CF and fertility. So 95 to 98% are infertile because of the lack of those two tubes, the congenital bilateral absence of the vas deferens. Also, the epididymis may be smaller, there may be atrophy of the seminal vesicles. And me as a pulmonologist, I'm not really going to be great at diagnosing that. But I do send our males out for semen analysis, and it does two things. Is there any sperm present, but also it looks at the quality and how it's actually moving. And then you can also do ultrasound as well to detect the absence or presence of the vas deferens. And one note on ejaculate. So men with CF are known to have a smaller volume of ejaculate, mostly because CFTR is in the prostate, and that's where a lot of the volume comes from. And there's a case series, and then anecdotally, my patients will tell me after I started Trikafta, I had a lot of testicular pain, likely due to the increased volume that was in the testicles. That actually shortly goes away within weeks after starting Trikafta. So, can the increase can we see increased male fertility when starting on Trikafta, for instance? So unlikely, right? Because we can't regrow or grow in the first place the vas deferens. And so we haven't seen any cases of males just all of a sudden having fertility. and but what we did see in ferret studies is that ferrets who had CF and that were given ivacaftor while they were pregnant and had male kits or male babies actually were born with the vas deferens. And one of my favorite, probably all-time presentations was at the NICFC 2 years ago, where there was a case presentation given where there was a female with CF who was eligible and taking Trikafta, and they knew before her son was born through amniocentesis that he also had CF. She remained on Trikafta throughout the pregnancy, and he was born with vas deferens, which is pretty amazing. Was born at normal weight, and that was about 2 years ago. So there should be some more updates on that, but more to come. Moving on to contraception in CF. So nationally in the US, combined oral contraceptions or the pill is the most commonly used contraception in the US. And colleagues did a survey at 3 centers several years ago looking at the type of contraception that women use with CF. And again, 42%, it's kind of similar, to the general population use oral contraception. And then barrier methods like the diaphragm or condoms, 34%, long-acting reversible like an IUD, for instance, 26%. But notably, a quarter of our women with CF were not using any method. And then what are the impact of modulators and any drug interactions on contraception? So for each of the columns here, you have the 4 modulators that we know. So ivacaftor's Kalydeco, ivacaftor combined with lumacaftor is Orkambi, ivacaftor and tezacaftor combined or Symdeko, and then ivacaftor, tezacaftor, elexacaftor's Trikafta. You can see that the 3, ivacaftor, tezacaftor, and elexacaftor, they have no drug interactions. But what we did see with lumacaftor, which is Orkambi combined with ivacaftor, that actually increased the metabolism of our hormonal contraception. So that basically resulted in decreased effectiveness. So we really, at that point, had to counsel all of our women with CF, if you do not want or intend to be pregnant right now, that you should use another form of contraception. And there's like a study that just ended a couple years ago that actually should be published in the next couple months called the Case for CF. And this was assessment of contraception safety and effectiveness in CF. And this was done by Maura Aiken and Emily Godfrey, University of Washington. And what they did was, using a retrospective study, looked at past contraception use in women with CF and looking at CF related complications, pregnancies, all sorts of topics. And this is just kind of high level of some of the things they found, is that, as we know, pregnancies increase after Trikafta became available. And among the participants, contraceptive use was universal, kind of echoing some of the older studies that I just mentioned. Only half of pregnancies ended with a live birth. So there was miscarriages or planned abortions. And then unplanned pregnancy was very common, still kind of echoing that 20 to 50%. So there is truly a need to improve our counseling for our patients if they do not intend to become pregnant, for our reproductive age women with CF. So let's talk a little bit about pregnancy and CF. And before I get to that, I do want to mention that there are lots of options for our families with CF to have children. It is not just to biologically, naturally, quote unquote, have children. So adoption, step parenthood, fosterhood, surrogacy. So I think it's important to mention to all of our families with CF that there's lots of options out there. We know that a lot of our women, people with CF, do desire to become pregnant. A retrospective study in Europe and in the UK showed that about 40% had attempted pregnancy. This is over 600 people. And then Tracy Kazmersky and colleagues surveyed almost 200 females with CF at a young age, 15 to 24, and asked about a lot of questions about their sexual and reproductive health. And 78% of these young women said they wanted to have a child in the future. There was another study in Australia, smaller, that showed that out of 6 out of 11 participants had tried to get pregnant, but all 11 wanted children. So I think the majority of our women with CF do want to have children someday. And so this is one of my favorite slides. And this is from the CF Foundation registry starting in 2012. These are the number of pregnancies over the year. And this is where Trikafta was approved. So you can see our pregnancy rate in it alone doubled or tripled. And so this is where I really had to say to my women with CF, you don't want to have kids, we need to really talk about that. But if you do, this is a great time to try. And so a quick note about assisted reproductive technology, for short, ART. So I'm going to show the women's side and the men's side. But to go over the abbreviations, IVF, in vitro fertilization, which I think most of us are familiar with. But on the left side of your screen, that usually starts with hormonal shots to kind of get the eggs kicking and going, go through egg retrieval using ICSI, intracytoplasmic sperm injection, to get the eggs and the sperm together, and then implantation. And so IUI is intrauterine insemination. And then on the male side, we've got Tessie, Tessa, Pessa, Messa. And all of that basically is where we're extracting the sperm, whether it's an aspiration, extraction, whether it's from the testicle, the epididymis, but there's lots of different ways. And I leave that up to our urological colleagues to decide. So pregnancy care in CF. And so what are our outcomes when our women with CF do become pregnant? So there was an older study of the CF Foundation patient registry of note. This was way before modulators. And importantly, it showed there was no survival disadvantage for pregnant women with CF versus not with who were not pregnant. So great news there. And then a more recent study was the epidemiologic study of CF for 1994 to 2005, still before modulators, that did show when women were pregnant, they had more exacerbations, needing IV antibiotics, lower quality of life, but they did not have disease progression or an increase in mortality. So, what do we do for our side when a woman with CF says, "Okay, I want to, try and have a baby"? First things first is definitely carrier screening of their significant other. Um, and so we have a specific lab sheet we give to all of our patients. There's Quest, there is LabCorp, and then our lab at Hopkins. And we know that there's over 2,000 mutations that cause CF, right? There, if the significant other, the reproductive partner, maybe goes to their primary care physician who is not used to caring for a person with CF, they may order a random test. It's not their fault, but that may only cover 40 mutations or so. So we really need to know whether that reproductive partner is a carrier. The next thing is early referral to maternal fetal medicine. And we have a partner who's head of a maternal fetal medicine at Hopkins, and she delivered one of my patients 10 years ago, and she said, "I want all of your CF moms. I want all of them." And she has now probably delivered at least 40 or so babies, and sometimes twice to the same mom. And so some of our patients live close and will be delivered by her. Some of our patients are 3 hours away. So depending on lung function, they might have one visit with her and say, "Okay, you're healthy enough. You can go to your community OBGYN. But if I'm here, we've met. If something happens, we have that as a backup." We optimize nutrition. And so pancreatic enzymes, vitamin supplements, and then really try to control hyperglycemia. A third to a half of our women with CF already have CF related diabetes. Some develop gestational diabetes, and that can lead to issues with the fetus. And so we're really concentrating on those. And so, what is the impact of lung function on pregnancy? So, moderate to severe disease, FEV1 less than 60%, does put you at risk for preterm delivery, need for C section, and low birth weight. And Raksha Jain and colleagues show that there was a 2% decline in FEV1 in pregnant people with CF not on highly effective modulator therapy. So it's an extra little kind of group of people that we really need to watch. And so, what chronic therapies that we can continue during pregnancy? And this is a long list, but basically, what I want to show you here is that a lot of what we do, we can continue safely. So, mucolytics like pulmozyme, hypertonic saline, even our inhaled antibiotics, there's little to no systemic absorption. So, we can continue those both in pregnancy and in lactation. Our enzymes, nutritional supplements, and our modulators, which we'll get into a little bit more. And so, what are CF clinicians doing? So, Christina Montemayor and myself, we actually surveyed the US physicians community a couple years ago, said, "Okay, how comfortable are you with prescribing, or are you continuing some of these therapies by trimester?" So, first trimester, second trimester, third trimester. And really, pancreatic enzymes, hypertonic saline, pulmozyme, vitamins, pretty comfortable. You can see azithromycin does drop off, which is quite interesting, 30 to 40%. And then the highly effective modulator therapies, which include ivacaftor and then Trikafta, mostly are comfortable continuing. But you see only about half were comfortable with Orkambi and Symdeko. And I hypothesize that's likely because those two modulators were less effective. So does the benefit necessarily outweigh the risk? And so what happens when pregnant women with CF stop modulators? And I really like this case by Aaron Trimble and Scott Donaldson that had 3 cases. And what they showed was, so if you'll just look at the top graph, every arrow represents a pulmonary exacerbation needing IV antibiotics. The big vertical line is where they started ivacaftor. And then during pregnancy, perhaps, which is the stars, they stopped ivacaftor And you can see what happens is the lung function drops right away. So the squiggly lines is lung function. So you can see in all three cases that the minute that these women stopped their ivacaftor because they weren't sure if that was safe in pregnancy, lung function dropped, an exacerbation occurred, et cetera. And then there was also in the phase 2 Trikafta trial, there was 10 adults, and then 6 months pre and post after the trial ended, there was lung function decline in 7 out of 10, exacerbations returned, et cetera. And so here is an international survey with Dr. Jennifer Taylor-Kauser in the audience and Ed Nash. And so they looked at use of CFTR modulators in pregnancy. And initially, this first survey was looking at ivacaftor, tezacaftor, and lumacaftor, so before Trikafta, and looked at an international study. So this was a total of about 69, I believe. And you can see that the majority were on ivacaftor or lumacaftor ivacaftor, and only 7 were on tezacaftor, but that was just because that had just kind of recently come out. And you can see that the ages were young, in their 20s, and FEV1 was higher in the ivacaftor group, 90%, not surprising. That's the one with the higher highly effective modulator therapy that's associated with the increased lung function improvement. And then there was presence of CF-related diabetes, et cetera. And what they concluded from here was the CFTR modulators are well tolerated in pregnancy. In the green is the percentage of women that stayed on ivacaftor in the first trimester, second trimester, third trimester, and then all trimesters. And then the blue is lumacaftor ivacaftor, and then the yellow is tezacaftor ivacaftor. And so what there was 2 pregnancies that ended in a first trimester miscarriage, which I will get to the rates of those, and 1 pregnancy was terminated due to health reasons. And so the use of these modulators, and these, I believe it was 69 or so, was resulted in 2 maternal complications that the physician who was treating them deemed relevant or possibly related to the CFTR modulator. One, I believe, was a pulmonary exacerbation. The second was leukemia, which I don't think have ever seen since, but the treating physician had to kind of document it that way. I don't think that we think in the general CF community that modulators cause leukemia. So it unfortunately was a unfortunate kind of two things happening here. What we do know in the general population is that the miscarriage rate in women without CF is 10 to 15%. The miscarriage rate here was about 4.7%, so much lower. And then the cessation, so the stopping of the modulators in women in 9 actually caused so much clinical decline that they actually restarted their modulator. And importantly, there were no modulator-related complications that were reported to the children that were born. So then Dr. Taylor-Kauser and Raksha Jain used the same survey and repeated it a couple years later in our Trikafta population. So there were 47 here and kind of similar age group and baseline FEV1 by about 75%. And then you can see the number out of those 47 that were on it during conception, first trimester, and throughout lactation. So at least half kind of stayed throughout. And so kind of a summary of both of these studies is there were, 61. I knew the number was going to come to me. But there were 66 pregnancies. There was twins, I believe. But basically in the first study, the 2 maternal complications were deemed secondary, but there was clinical decline, but no modulator complications were seen in infants. And then this last study with Trikafta, there was also clinical decline when 6 of these women stopped it. There was 1 maternal complication deemed secondary to Trikafta, which is cholecystitis, which I actually do believe. We've seen that in men and women on Trikafta, some gallbladder issues. So that one I do think is very relevant. And there was 2 complications that seemed deemed unrelated, and there was 3 complications in infants deemed unknown. So transient rise and then fall again, and liver function tests, and some congenital malformations, but unknown whether that was related to the Trikafta or not. And so this was a total of 135 women with CF, where they stayed on their modulator during or throughout part of their pregnancy and lactation, and the miscarriage rate was very low. And just again, out of the 39 people where they stopped their modulator, a third had to go back on because they declined so badly. And there were no modulator associated complications that were attributed to the infants. And so another survey that was done by Christina Montemayor and myself where we asked the physicians in the US about how they were treating exacerbations during pregnancy. And so for a mild pulmonary exacerbation, so usually meaning increased symptoms, maybe a 5% or less drop in FEV1, what were they doing? The overwhelming majority was using an oral antibiotic or an oral antibiotic plus an inhaled antibiotic. For severe exacerbations, maybe that's a 10% drop in FEV1 and maybe it's hospitalization. Still sticking to current guidelines, two IV antibiotics or maybe an IV antibiotic and an inhaled. And so what we're seeing here, what we kind of do clinically is we treat the mom how best they need to be treated. And I've had several women with severe lung dysfunction who are pregnant with severe infections. I've had someone who had to stay on IVs for 6 months out of her pregnancy. And OB-GYN was like, treat her how she should be treated. We want to keep her as healthy. And a couple of these, both of the women that I can think of actually had great babies that are now, one's like 10 years old, one's 6, and doing great and fine. So normally that's the response you'll see from our OB colleagues is if they're sick, we need to do what we need to do. But if they're okay, we try to avoid certain ones. So here's a table that Christina Montemayor and Rakshit Jain and put together. So, and I believe, Jen, you were another co-author on this as well. So pulmonary exacerbations, what can we use to treat? We typically, if we can, try to avoid fluoroquinolones, aminoglycosides, and Bactrim in certain trimesters. And so most of the time we can do that. But as you can imagine, so Dr. Hoffman just showed you that half of our adults, 60%, have Pseudomonas. The oral options we have are fluoroquinolones. So it becomes pretty tough when we're trying to treat someone who's pregnant with an exacerbation with basically not a lot of oral options. And so that's when sometimes it's our inhaled antibiotics that come into play more often if we can get away with it, particularly if they're on modulators. And so another thing that we asked in our survey was, what are topics that you feel as a physician are extremely important to discuss, but how comfortable do you feel discussing them? So all the way on the left, physicians felt it was very important and they're pretty comfortable discussing CF medications, nutritional status, treatment of exacerbations. We get in the middle, like gestational diabetes, 66% said it's super important, but only 11% said, I feel comfortable doing that. I need to leave that up to my endocrinology colleagues. Miscarriage, gestational hypertension, pregnancy termination, less comfortable, but still important. So going on to lactation. So how do modulators affect and impact the breastfeeding infant? So in all the modulators, we know that the modulators are present in breast milk. And then in some of the rat studies, we do know that there's cataracts that were observed in the ivacaftor study. And that would be the same for all combinations since ivacaftor is the base for all of our modulators. And doctors at UNC actually reported a case with a person with CF who breastfed while on Orkambi, and they were actually able to measure both in breast milk. And so breastfeeding during treatment with CFTR modulators, and this is part of Jennifer Taylor-Kauser and several other colleagues across the world, where they looked at 69 infants that were breastfed while on modulator therapy, and there were no reports of rise in LFTs in those infants, and none of the infants had cataracts, with a caveat being only 6 out of the 69 were actually tested for cataracts. So, general guidelines for newborn and infants monitoring when mother is on CFTR modulators. So, we should screen for those infants who were exposed during pregnancy and via breastfeeding. In animal models, ivacaftor exposure while they were young rats actually did lead to cataract development. The risk is very, very low. And there's been very few reports in infants and children on ivacaftor or ivacaftor lumacaftor. Um, and one thing to note is, excuse me, I also tested a little dry up here. um, One thing to note is newborn screening, just kind of a little off topic of this, of someone who continued, of a mom that continued CFTR modulators during pregnancy, because if they end up having a child with CF, the reliance on the immunoreactive trypsinogen, which is a measure of pancreatic insufficiency, which is how we do the newborn screening, could lead to a false negative. So if there is a father who is known to be a carrier or the father's carrier status is unknown, we do actually recommend doing a sweat test and genetic testing to ensure that we need to make sure that the infant doesn't also have CF. And then also just considering liver function tests in newborns and infants that did continue on CF, the moms continued CFTR modulators during pregnancy and lactation. And so I did want to give a shout out here to the Women's Health Research Working Group. This 5 of us formed in 2018. And so Dr. Jennifer Taylor Kauser here in the audience was our first chair, and Raksha Jain was our first vice chair, along with Tracy Kesmercy, myself, and Myra Aiken. And this came about, we were at NACFC, and we all kind of had talks or posters or something where like, we should all get together. We all had different I had a difference in women exacerbating versus men. And there was a lot of things. So we kind of started, our first ideas were on a napkin, kind of like the Beatles wrote songs on napkins. That's what we did. And this has greatly expanded over the next 6 years. We have, Moira Aiken retired, but we have a dietitian, a psychiatrist, research coordinator, 2 women with CF, and OBGYN. So there's a huge group. And then we have renamed our group Sharing. And this is our little motto here. And you can find our info on cff.org, but our mission initially was, hey, we need to identify the gaps in knowledge and determine future research priorities. We have a bunch of studies, which I can't even get to all of them today. I'll get into some of them to really move this research forward. And we've also helped form a men's working health group. And so Tracy Kesmersky leads that, but we have endocrinologists, urologists, someone from the CF community. So they are also leading a separate group as well. So one of the studies that I think is just really fun, led by Jennifer Taylor Kauser and Raksha Jain, is Mayflowers. So this is a prospective pregnancy study, and we are enrolling people during pregnancy and then following them at delivery and then 2 years after delivery, both mom and child. And there's 2 sub-studies, one, which I find really fascinating as well, and that our site is one of them, is getting Trikafta levels in cord blood, baby's blood, mom's blood, and breast milk. And it's been really fun for me to try to coordinate that with a lot of different subspecialties. So I was like, how in the world am I going to get cord blood? And I called up the maternal fetal medicine doc that delivers all of our babies. She said, yes, we can do that. I've got it. I've got you. I'm going to hook you up with the NICU director who will get blood from baby. And so I'm fascinated to see those results when they come out. So the patient population is about 300 participants, hot off the press as of half hour ago when I asked Jen. We've enrolled 273 patients. So it's been really well ongoing. And then, so this is just the study graphic, and again, following mom and babies out for 2 years. And so the outcomes that we're looking at, lung function, pulmonary exacerbation in mom, weight change, And then any sort of pregnancy complications for obstetrics, delivery complications, any preterm labor, bleeding. And then for baby, of course, birth weight, gestational age, any instances of cataracts, and then any instances of needing to be in the NICU. And then Tracy Kazmersky is following this up in a separate study called HOPE. And this is got a foundation by not just the CF Foundation, but the NIH. So it's a long-term study. And there's two parts to it. So it's really looking at the impact of being a parent on your own health outcomes. So there's been two aims. One is closing up soon, where we're retrospectively doing a quick survey and tying anyone who's become a parent in the past decade to their information in the CF registry. But we're also using people who are not parents and tying their information to the CF registry and kind of comparing the groups. And then the second aim is beginning this year as well, where we're now going to prospectively follow new parents. So anyone that has become a new parent from now on. And so there's 18 centers, and it's going to be really fascinating. So in conclusion, we know that HEMT, highly effective modulator therapy, has improved outcomes. And so now people are saying, hey, I want to become a parent. I want to go to retirement. And nearly 90%, 93% are eligible. And we know that the numbers of pregnancies have tripled in the past decade. And I've just shown you that some retrospective study, it seems that highly effective modulator therapy is well tolerated in pregnancy and lactation. But the prospective studies that we are currently doing are well needed. And so I think we also need interventions so that we as physicians are comfortable in tackling all of those issues, not just what we can continue during pregnancy, but we may need to talk about miscarriage and other things that we may not be as well versed in.